Thank you for joining us for tonight's educational webinar on bunions and flat feet. Tonight's speaker is Dr. Nick Cheney, OrthoNeuro orthopedic foot and ankle surgeon. Dr. Cheney is a board-certified orthopedic surgeon who specializes in foot and ankle surgery. His practice emphasis includes ankle arthroplasty, heel pain, bunions, hammer toes, fractures, and foot and ankle sports injuries. Please type your questions in the Q&A box below, and Dr. Cheney will answer your questions following his presentation. Dr. Cheney?
Oh, thank you, Heather. Good evening. So hopefully we'll make some sense out of these things. I'm going to talk about how an arch collapse contributes to foot pain, specifically flat feet, bunions, and ball of the foot pain, because I see a lot of all three of those things. And so hopefully we can make some sense of this for you. My background, I'm a Lima, Ohio guy, born and raised, went to University of Texas in Austin first. And then transferred back to the Ohio State University. I swam in college, so I started out in Texas and came back to the homeland. Medical school at Ohio University, internship, residency here in Columbus through Doctors Grant and Children's. And then I did my fellowship up in Grand Rapids, Michigan, which was quite interesting with the Michigan fans up there, but we made it work. So all of these problems are related to an arch that is beginning to fail or has failed. Basically, what happens is as the arch fails, weight shifts to parts of the foot that aren't designed to take it, and that ends up what causes the pain. It's not so much pain for pain's sake, it's the foot collapses, weight shifts places it shouldn't be, and that causes pain. So all of these things are connected, as you'll see as we go through this. So the foot is an arch, and so I like this keystone diagram in the middle. You can kind of see that keystone in the middle where everything builds off of that. And if you take that out, it falls apart. The image on the left kind of shows you how the foot is loaded. So if you look at this area here, okay, that's kind of the keystone of the arch. As you can see, the body weight comes down more over the back of the heel so that we can have the front of the foot to propel ourselves forward when we walk. But if that weight's not distributed so that you've got half the weight on the front of the foot and half the weight on the heel, that's going to cause things to fail. As you can see, you've got your tension side as it's being pushed down and the compression side up top. And then the other thing to keep in mind as we go through this is we look at two main arches in the foot. You've got your longitudinal, your medial column, your longitudinal arch, and your transverse arch. And these things all begin to break down over time. And so I follow the Grand Rapids arch collapse model. This is Dr. Bohe on the left and Dr. Anderson on the right, both of which were my fellowship directors. And this is the Grand Rapids arch collapse progression. And interestingly enough, the old arch failure classification system has evolved to something more along the lines of this, where they understand that it's not the arch tendon that fails, and then the arch goes, the arch fails, and then the arch tendon goes. And so we'll run through these stages 1 through 5. The important thing about this is it's not necessarily a progression through it. Where patients present can vary based on the stage. They don't always present or have symptoms of stage 1 or 2 before they get to 3 or 4. And so it's basically, they describe it as a snapshot of where the patient is when they present. The picture on the left is one of my mentors, Dr. Anderson, with Dr. Sig Hansen on the right, who's kind of one of the big wigs and one of the higher ups when it comes to orthopedic foot and ankle surgery. And then on the right is a picture of Dr. Anderson during my fellowship year and myself as I was finishing up that year of learning. So the Grand Rapids arch collapse stages 1 through 5, it's a progressive failure of the foot, predictable stages. Early stages, there's not as much architectural change. Radiographically, the foot doesn't look as abnormal. And then the symptoms evolve kind of from the front of the foot and work back towards the back of the foot. So type 1, stage 1 is early arch stretch. So you've got the weight coming down over the ankle. You're overloading the front of the foot, right? So you've got greater than 50% of the weight on the forefoot, less than 50% on the heel. And so you start to get some additional compression on the top, some tension on the bottom, and the arch, the soft tissues begin to fail. This is where you start to see plantar fasciitis, some Achilles tendonitis, and just generalized arch pain as things start to break down. X-rays are routinely pretty normal at this stage. And then you start moving a little bit further back in the foot. And stage 2 is when you start to see metatarsalgia and bunions. Metatarsalgia would be the pain in the ball of the foot we'll touch on. So if you're looking at this foot diagram here, I'll show this to patients in the office with their x-rays. These are the metatarsal bones that support the weight on the front of the foot. So these metatarsal bones right here. And so if you're overloading the front of the foot, this first metatarsal is bigger than the others because it's designed to take more weight. And so remember the medial longitudinal arch here. This first metatarsal, as you're levering on this, okay, the ground is pushing up here, you start to cause hypermobility and some stretch of the soft tissues down here so that the tension failure and the compression side up here, this first ray starts to elevate a little bit, or it starts to drift into what we call varus or a bunion deformity because this joint becomes tired. So think about a teeter-totter. The ground's pushing up here, it's causing stress here. And so then that allows this first ray to become what we call hypermobile, and it allows some weight to start shifting over to these lesser metatarsal bones, not intended to take it. And so you can start to develop pain in the ball of the foot or to develop a bunion as that longitudinal arch begins to fail. Stage 3 is when the medial column collapses. So the medial longitudinal arch is beginning to fail, has begun to fail. And so now these lesser metatarsals are being overloaded. And so you're overloading at these joints, which is that keystone where they're not really designed to move at all. And so as they break down and they're overloaded, they start to become arthritic. And so you start to get arthritis to the midfoot. That's a stage 3. Type 4, so I try to keep these images so you can kind of see stage, 2, 3, 4. Stage 4, so your medial longitudinal arch has failed, your transverse arch has failed, and now your arch tendon, the posterior tibial tendon where it inserts here, is beginning to fail because the support structures in the arch are failing, and so this tendon's having to do extra work to try and fight that collapsing arch. Again, another image here. So you've got the foot collapsing here, more strain on that arch tendon, the foot starts to tilt. And then stage 5 is one that we really don't like to see, where the arch tendon is then failed. And so now you start to see failure of the ankle at what's called the deltoid ligament. And that is a very challenging problem as we don't have a lot of great options for that. We've always got new things that are coming out to try and treat that. But that's basically, as you're progressing through this, we're trying to avoid this problem here where that deltoid ligament fails. So it starts in the front of the foot where you're loading the first ray. The first tarsometatarsal joint starts to get unstable and the medial column fails. Then the transverse column fails. Then the arch tendon fails. And then ultimately the ankle fails. And so you end up with what we call valgus ankle arthritis. So the ankle's tilting in what we call valgus, kind of tilting towards the outside. So what causes this arch to collapse? Well, it's typically due to a contracture of one of the muscles in your calf. So you have these two muscles here, the gastrocnemius and the soleus, and they originate on different spots on the back of the leg. The gastrocnemius actually starts just above the knee on the back of the thigh bone, and the soleus starts on the back of the shin bone. And they merge somewhere down here just above the ankle to form the Achilles. So two different muscles, two different tendons that merge into one that form the Achilles. And so the gastrocnemius is typically the root cause of this. So that's typically contracted, and it causes an overload to the front of your foot. Again, the first ray supports more weight, and so as you're overloading that, you're going to create some hypermobility to that medial column, and that's going to allow the arch to begin to break down. So how do you test for a tight calf? So this was actually an image from the office when I was a fellow, Dr. Bohe performing what's called the Silver Skull test. You've got to perform it the right way. We wrote a paper back in 2020 on the correct way to do that. To make sure that you're identifying this if present. And so you can see on the top image, they've got the patient's knee extended. And so we're tensioning that gastrocnemius muscle because remember, it starts above the knee. And then the patient bends the knee, and that relaxes the gastrocnemius up here, and we're checking for the tension in the soleus. So you can't just check for the Achilles tightness, you got to check for both. And importantly, you've got to make sure you're doing a two-handed technique to make sure you're getting motion just through the ankle joint. And you can see the difference in the angle of the foot between the knee extended and the knee bent. So when the knee's extended, the foot doesn't come up as far. That tells us the gastroc is contracted, because if the gastroc was not tight, it should be at this angle, just like with the knee bent. So here's an example of what a normal silver skull exam should look like. That's my daughter when she was 4 years old. She's now almost 16. But you can see with the knee extended, the angle is no different than with the knee bent. So that's what a normal silver skull should look like. So metatarsalgia, pain in the ball of the foot. I saw a handful of patients today with this problem. Typically, patients will come in, they'll kind of point at the base of their toes. It's killing me right here. Sometimes it kind of radiates up the foot. Again, that overload to these bones can cause pain that radiates up these bones. I'll ask the question, is it worse if you're barefoot on a hard surface, or does it feel like you're walking on a marble or a bunched up sock? And if you look at these images, these metatarsal heads are kind of shaped like a marble. And so it'll feel like that when this big toe is able to elevate a little bit because this joint is tired. You're loading those bones that weren't designed to take that weight. So this is a stage 2 collapse, right? So that medial column is incompetent. That big toe joint at the midfoot is too tired. And so it allows weight to start shifting over here. You can get stress fractures from this. I get a lot of patients that come in with metatarsalgia symptoms. Maybe they've been seen in the urgent care and they've been told they have a stress fracture, even though the x-rays are normal. Most of the time, you don't have a stress fracture. I've seen on rare instances, patients will come in and there's actually a stress fracture associated with this, but it's still caused by the same thing. So when the weight is overloading these lesser bones, you can get stress fractures through the shafts of these bones, but it's not very common. So how do you treat this? Again, the arch is broken down, weight has shifted places it's not intended to be. And so I start by trying to treat the symptoms. And so you've got these smaller bones taking more weight. So I typically recommend, sorry for the screen, aggressive calf stretching. Again, trying to offload the forefoot, treat that tightness in the calf. So here they're doing the calf stretch with their knee extended to tension that gastroc that starts above the knee, and they're leaning into the wall doing the stretch. And then we put a pad on that sits right behind those metatarsal heads, because what we're trying to do is redistribute weight over this circle should be up here. We're trying to take weight off those small pressure points and redistribute it over a bigger surface area. And it looks something like this. We use something generic in the office initially as a trial to try and just see if the patient responds to it. If the patient responds well, then we talk about maybe doing a custom orthotic at that point. We don't typically recommend a custom orthotic right out of the gate because they can be quite pricey. Most insurances don't cover them. And so we try to do something inexpensive to see if it works first. And if it does, then it's probably worth investing in the custom orthotics as a more long-term treatment solution. This orthotic adjustment or modification is not going to correct what has broken down and basically rebuild the arch and restabilize things and make it so that you don't need the orthotic. If you need it, you need it probably for a lifetime. Personally, I have this problem. I had it right when I started my fellowship to learn these things, and I've been wearing them ever since. And it's not going away because I've got a hypermobile first ray, loose joint here, and the weight shifted over, and so it's loaded more. But if that works, then we can do the custom orthotics. You can get an neuroma. I see a lot of patients that come in with this forefoot pain that have been told they have neuromas. They've had injections. They've had surgery to take the neuroma out, but they still have the pain. For me, the neuroma is caused by the same overload. So you've got the bones and joints here that are overloaded. And so the nerves that run in between, called the interdigital nerves, are taking excess weight as well. And sometimes it can get swollen and inflamed and create a neuroma. Regardless, I treat it the same way initially. I'm trying to shift weight off that area, redistribute the weight, and try to improve symptoms. So what happens if the orthotics don't work and the patient's miserable and they can't tolerate it? I tell them they basically, they have three options when it comes to surgery. We could do a simple little surgery where I just do what's called a gastrocnemius recession to alleviate that tension in the calf to try and offload the front of the foot. And sometimes that with the orthotics is enough to control the symptoms. Just offloading the front of the foot allows the orthotics to work more efficiently and effectively, and we can avoid bigger surgery. The second option would be to do the calf stretch and then potentially come in and shorten some of these bones, which requires a little less healing, but it doesn't address the instability to the first tarsometatarsal joint, that medial column. And as you can look at this X-ray, the patient clearly has a bunion. And then you can see the excessive length of these second and third bones in relation to the first. And so that allows them to take excess weight. So you could try to shorten those down, but with the bunion like that and the instability here, it's probably not going to work all that great. But it's an option, especially if there's not a severe bunion. And the most definitive option would be what we did here on this X-ray here. Here's the pre-op, here's the post-op. We fuse that first tarsometatarsal joint and correct the bunion through that. Even if there's no bunion, we can still do this to provide stability to that joint. And then we want to shorten these bones down to try and recreate a normal parabola so that the weight could be distributed the way it was intended. So you can see the difference. The foot's narrower. The first ray is now the same length as the second, and then you've got a nice gentle parabola with nice balance to the forefoot. Bunions, all right. So everybody's seen this before. You got a big bump on the inside of the toe. I get patients all the time that come in and think it's a growth. It causes pain with shoe wear. I've seen patients, cutting outside the inside of the shoe to make space for it. Patients that, have to wear sandals even in the winter because they can't get into a shoe comfortably. That's probably the more common presentation is the pain from the bump. You can also get pain with range of motion. So when you're walking and that joint's moving, it can cause pain. I've had patients where because the great toe is pushing into the second, they get a lot of second toe pain. They may not have pain from the bunion, but they're getting a lot of second toe pain or some skin irritation from that deformity to the big toe. Again, this is a stage 2. So that first tarsometatarsal joint has gotten tired, and the bone begins to drift into what we call varus. And when the first metatarsal drifts into varus, the toe then goes into what we call valgus compensatorily. So the body has a way of trying to keep things in a reasonable alignment, even though this is crooked. The body tries to compensate by forcing the toe into what we call valgus. So normal looking X-ray with a bunion here. So the bone itself, there's no excess growth. There's no the bone doesn't grow crooked. There's no growth off that bone to create that prominence. The bone literally goes from straight to what we call varus. And again, it's due to the arch breaking down primarily at this first tarsometatarsal joint. So that becomes loose and the bone starts to drift and rotate. Again, my point, the bone didn't grow crooked. It just shifted over. So how do you treat it? There's not a lot of great conservative options for that. I tell patients try to find a shoe that accommodates it, that controls symptoms. I do recommend these bunion pads just to try to cushion the toe or cushion the prominent first metatarsal. We talk about calf stretching. They do make like the bunion correctors, the splints. Patients are always curious if that's going to make the bunion go away. It doesn't. It's not going to fix the deformity. You're going to spend some money. It may make you feel better, but it's not going to fix it. If it makes you feel better, that's great, but it's not going to fix the problem. So when do you consider bunion surgery? So I see lots of folks come in, with the bunion deformity. We talk about it, we explain how they get it, what causes it, what our options are. And I'd probably say 9 out of 10 patients I talk out of surgery just because it doesn't hurt bad enough. It's not enough to go through the surgical correction. A lot of times I get, a lot of females want to get a cosmetic correction. The problem with doing a surgery to correct a deformity without pain is you can take something that doesn't hurt and you can very quickly make it hurt by doing surgery on it. So I typically will fix these for pain, not cosmesis. Trying to do anything with cosmesis can lead to problems. So how are these fixed? There's about 150 to 160 different ways that have been published to fix these things. The majority involve cutting a straight bone and making it crooked to try to to try and correct the appearance of the toe. It doesn't fix the deformity, it corrects the appearance of the toe, not the x-ray, the appearance of looking at the foot. The problem with many of these is that when you cut this bone, you're not addressing where the problem's coming from, and there is a high recurrence rate with those moving forward. The other thing that's gotten real popular is minimally invasive surgery. So you're trying to do everything with small burrs, and then you're putting these screws in, and you're just shifting this bone way over. Again, it can make for a good-looking foot, kind of a goofy-looking X-ray, and it can work, but it also has a recurrence rate. And so my preference is to try and do something that fixes the problem and tries to prevent recurrence. And so I do what's called a modified lapidus. All right. So the deformity develops here. I try to spin that bone back to where it should be. So I get these little sesamoid bones realigned. I close down the angle between the first and the second metatarsals. And then I'm trying to fuse the first tarsal metatarsal joint into the base of the second. And that tries to prevent any kind of rotational or gapping between those bones. And we had pretty good results that we published in 2021. So I use 4 screws for this. It's a fairly inexpensive construct. I'm sure a lot of people on this thing on the webinar have probably heard of Lapiplasty. It's basically the same concept. They marketed it, and they use a $7,000 implant to try and accomplish what we do with 4 $50 screws. So there's a big price difference. Same outcome. So a lot of times folks will ask, does this impact my ability to run, hop, skip, jump, dance? It doesn't. The joint that we fuse is considered essentially a non-essential joint. And so when we fuse that, we're taking motion away from a joint that really isn't designed to move much. As you can see, maybe 1 to 1.5 degrees of motion. And so it doesn't really change anything. I've done this on high-level athletes. I take care of high university athletes. I've taken care of some Olympians. And so it doesn't impact the ability to do anything that you want to. So just an example of before and after. So I tell patients, it looks like these little bones have shifted over, but they haven't. This first metatarsal, because the lucidus here is drifted this way, those little bones stayed the same. So my job is to reposition this first metatarsal right over those bones to recreate a normal functioning joint and try to get that to heal. Flat feet. All right. So this is another common thing. And this is what you'll see. Some people sitting on here may be looking at a foot that looks like this or a heel that looks like this. And patients will come in and describe it like my foot's tilting in. I'm having pain on the inside of the arch. This is that stage 4 that we talked about where the longitudinal and the transverse arches have failed, and now you're getting failure of that arch tendon. So remember, the longitudinal arch has failed, the transverse arch has failed, and this green line, that posterior tibial tendon, the arch tendon, is now overworked, and it is not nearly as strong as those tight calf muscles that are going to drive that arch collapse. So what do we look for? So a lot of times you'll see, the too many toes sign. The heel starts tilting out in valgus. You've got the flat foot posture. A lot of times we want to see if the patient can get up on their toes because that kind of lets us know double leg, single leg toe raises, whether that arch tendon is working. The arch tendon pain is kind of along the inside of that foot and the ankle. It can radiate up the inside of the ankle. You can get something called subfibular impingement, whereas that heel starts to tilt out. You can get pinching over here on the outside of the ankle. And a lot of times that's associated with startup pain. So as you first get up, those bones are now getting squeezed together and it causes startup pain. The inside, the medial side pain is typically more with walking, standing, those types of things. And so I want to see if they've got a tight calf. Is the big toe joint loose, consistent with the the longitudinal arch or the medial column failure. Too many toes sign as the arch starts to collapse. Just like if you take a tripod and you lift one leg, it's going to tilt in. That's kind of what happens to the foot. So here's what a flat foot X-ray looks like. So kind of flat as a pancake. There's no arch anymore. This is looking at the foot from the side. If you look at the foot from the top, we're looking at this joint primarily. And so I describe it as like the ice cream's kind of falling off the ice cream cone. If I draw a line down this bone right here, the ankle bone, the talus bone, it should point right down this first ray. And so if I draw a line down that, it's pointing way to the inside. And so that tells me that arch tendon is failing. So how do we treat it? Again, calf stretches. I'll start out with some orthotics. So you can see the heel and valgus here. We use an orthotic with a post to try and neutralize that heel, elevate the arch, and take some strain off that arch tendon. We can start with that first. If the pain's really severe, I use the orthotic and try to rest it in a boot because we're trying to calm down inflammation, try to get the symptoms improved. And then typically, if those things improve, progress to therapy. I don't typically do therapy until we've tried to rest it and immobilize it and calm down the inflammation. Because if we do the therapy doesn't help and we put you back in the boot, you get weakness, and then we got to send you back to therapy. So I try to be mindful of not spending too much time or money in therapy and try to do it in a methodical, meticulous manner. So when do we do surgery, right? Patients have done kind of the whole rigmarole of conservative treatment. We've got an MRI that shows the tendon is in bad shape. It's torn. It's severely diseased, and the foot has collapsed and failed. There's a couple different options. If I've got patients with arch tendon pain, but they haven't had a significant collapse to the foot, sometimes I'll do the simple little calf stretch operation, the gastrocnemius recession that I talked about earlier. It's a 2 or 3 minute operation. It's very, very benign, very low risk. We let you walk immediately afterwards in a boot. Just saw a patient today, no significant arch failure, arch tendon pain, some mild changes on the MRI. So we're going to try that and see if we can get away with avoiding bigger surgery. If the foot is collapsed, that's really not a great option. If the tendon's torn, ruptured, showing severe changes, we've got to transfer a tendon, and then we have to build the arch around it. And there's a couple different options to build the arch around it. We can do a joint sparing procedure where we don't fuse any joints. We do some osteotomies, and we try to reposition the foot around that tendon that we transfer to take the failed arch tendon's place. Because if we take that tendon and we transfer it, but we don't correct the foot that has failed, that new tendon is likely to fail very quickly and predictably. So we can do osteotomies where we basically cut some bones and try to reposition the foot around that tendon. We can do a joint sacrificing where we're repositioning bones and fusing through joints to it's a more powerful operation, but it's also now taking motion away from joints in the foot. Or we can do a newer soft tissue reconstruction. Most of this is a soft tissue problem, right? The tendon fails, the ligaments have failed, the joints have failed, and it's allowed the foot to collapse. And so my preference at this point now is to try to avoid all the bony reconstruction and try to stick by treating what failed first. So here's an example of a joint sparing reconstruction. So a patient with a flat foot, the uncoverage. So in this case, I did the calf stretch operation. We cut the heel bone and slide it towards the inside to try to get the heel back underneath the ankle. We transfer the tendon. I did fuse the first tarsometatarsal joint, again, trying to stabilize that joint, try to bring that down to correct the deformity that has developed to the front of the foot. And so you can see how things line up much better on this view. That ankle bone is now kind of pointing down the first ray. Same thing on the side view, looking at the foot from the side. That ankle bone is now pointing in line with the first metatarsal. You can do the joint sacrificing, the fusion. So this is a much more severe deformity. Typically, it's for more rigid deformities that aren't correctable. And so you can see this patient here has a severe flat foot. You can see that the ice cream is really falling off the ice cream cone here, and that ankle bone's pointing way towards the other foot. And so we come in and we do a corrective fusion through the joint below the ankle, the subtalar joint and the talonavicular joint, to spin that back into the correct rotation, and then correct any of the instability to the medial column by fusing this, bringing it back down, and we can get a nice correction to the arch that way. Everything's lined up nicely, and the patient did well. The soft tissue, I've gotten a little bit more inclined to do this. I'd like to try and avoid doing bony work as much as I can now that leads to potentials for bone healing delays or bones not healing. And so here's an example of a patient with a flat foot. Their arch tendon had failed. You could see how the ankle bone's pointing towards the other foot again. And so basically what we did is we come in and we reconstruct two ligaments on the inside of the ankle. We use a special graft. We can transfer the new tendon through that as well. In this patient, I did do the osteotomy to the heel. This was early on when I started doing this. I wanted to still try to get that heel in a better position. But you can see the difference in the correction, how this ankle bone is now lined up much better on the view from the top down. And then even from the side view, it's lined up much better where it should be compared to the pre-op images. So if we do any bony work, any kind of osteotomy where we cut the bone and reposition it, and then we have to put screws in or hardware to try to hold it there to heal in that position. An osteotomy, you're looking at 6 to 8 weeks. Any kind of fusion where you're trying to fuse two bones together through a joint takes anywhere from 8 to 12 weeks. Soft tissue healing does take 12 weeks, so it's a little bit longer, but I don't feel like it burns bridges. I don't have to worry about bones not healing. I can make fewer incisions. And I do feel like the correction looks better radiographically, and patients seem to be tolerating it as well or better. I can say this, that anytime I do this reconstruction, I've always kind of been underwhelmed in how the foot looks in recovery. Granted, patients feel better, but I'm always kind of dissatisfied with how the foot looks after we do that. Doing the joint sacrificing, I always worry about the ligament on the inside of the ankle, like that stage 5, because we've now taken motion away, and so now no more motion is forced to the ankle joint. So I always worry about that. With this reconstruction, I'm less concerned about all of those things because I'm kind of addressing that ligament on the inside of the ankle, the ligament between the two bones at the front of the ankle or the front of the top of the foot. I just feel like I feel like the correction looks better. It seems to be holding up nicely, and patients are doing well. And I think I'm limiting risk in that sense. All right. So I know that's a lot of stuff. I try to keep it as understandable as possible. There unavoidably some technicality stuff in there, but try to hit on those 3 topics, kind of what causes it specifically, and then how we treat it, both non-surgical, which is always the first option, and then if all that fails and the pain is sufficient enough, surgery. I always tell patients outside of a specific tendon rupture or a fracture, it's not cancer, it's not heart disease. It doesn't hurt bad enough. We don't have to do anything surgical with it. So open to any questions.
Yes. The first question is, can flat feet be hereditary and not painful?
Absolutely. My son has a flat foot. He didn't get it from me because I got a high arch foot. And so and I see this a lot in kids. Parents, grandparents will bring the kid in with a flat foot that's not painful, asking, do they need orthotics? They can have a flat foot naturally. It becomes a problem if the arch breaks down further and it becomes painful. But yes, you can be born with flat feet, have flat feet your whole life. There's other conditions, something called a tarsal coalition, where during your development, in utero, basically, while mom's still pregnant with you, and when you're born, bones can be connected that weren't designed to be, and that can lead to a rigid flat foot deformity that you can have throughout your life. That can cause problems eventually, but again, if you have a natural flat foot that doesn't hurt, you don't need orthotics, you don't need treatment for it until it becomes painful.
What is the best way to stretch my calves and how long do I hold the stretch?
So that picture that I showed, so remember the two muscles, the gastroc and the soleus. The gastroc starts above the knee. So we're checking for the tightness in the gastroc with the knee extended. So you always want the knee extended. So this is the one that he's stretching. So you want to have the heel flat on the ground. You want to lean forward, and you're going to feel a stretch in the calf up here. And so I typically tell patients, when they come in with a problem that we're recommending calf stretching to try to treat it, I'll say, stretch it for, hold it for, 20 seconds, do that 3 times, hold it 20 seconds, rest a little bit, stretch it again for 20 seconds, do that 3 times, then do that like 3 times a day. So just lean into the wall. And there's variations in how you can do this. I mean, heck, you don't have to lean into the wall. You can stand on a step, keep your knee straight, drop your heel off the step, and let that stretch in the calf here. You can be sitting down with your knee straight and grab a towel and pull the forefoot back, kind of wrap that towel around the front of your foot and pull it back and stretch it that way. But, a lot of times it's just doing more aggressive stretching that way.
Do you recommend orthotics for metatarsalgia?
Yes. Like I showed, that's the first thing we typically do is recommend the calf stretching and use that orthotic with that pad to try and redistribute weight on the foot.
Can one have a large bunion without a fallen arch?
Not routinely. No. The arch has to have failed to some extent. You can have bunions, like we know there's juvenile bunions, but typically they get worse with time, and it's because the arch fails.
Do all bunions need surgery?
No. Like I said, 9 out of 10 people, I tell them if they don't have sufficient pain, it's not worth doing it. If you're having skin breakdown problems, where that big bump is rubbing on the shoe and you've got a concern for infection, or it's bumping into the second toe, causing severe pain there and potentially some skin breakdown, concern for infection, I'll do it in those cases, even if they don't have sufficient pain, because if you get an infection, you got much bigger problems. But I tell patients it doesn't matter how bad the bunion is. I wouldn't fix it until it gets bad enough. It's just not worth having surgery if it doesn't hurt bad enough.
Will I be able to wear heels after a bunionectomy?
It depends on the type of bunion surgery you have. So of those 150, 160 ways, one of them that can be done is called a fusion of the first metatarsal phalangeal joint. So obviously the bunion develops here, and even here you can see the little bunion deformity. So instead of doing the fusion back here, you can do a fusion to this joint right here called the first metatarsal phalangeal joint. If you do that fusion, you're probably not going to be able to wear high heels. You might be able to wear a low wedge, but no high heels. Doing the lapidus back here, that preserves motion at the big toe joint, so you can wear whatever you want.
What's the recovery time for major foot surgery?
So it kind of depends. I mean, obviously, you've got different types of major foot surgery. Ankle replacements, there's one thing. Any kind of bony work that requires any kind of osteotomy or fusion. Typically, you're looking at 6 to 8 weeks non-weight bearing because those bones have to heal. As I tell patients, I don't heal bones. My job is to try to give the patient's body the best opportunity in which to heal them successfully. And so, kind of like this, if you look at this screw, dadgummit, this screw has got threads here. It's smooth, and you've got the head of the screw. And so we make the osteotomy and push the heel bone over. And then we put these two screws across it to try and squeeze those together. Bones heal best with compression and stability. So the non-weight bearing comes in by providing stability. Weight bearing can induce motion that can prevent bones from healing. So that's why the recovery is non-weight bearing for a lot of these things. Bone healing is what it is. I know there's different techniques that exist that talk about early weight bearing. They can do that if they want to. Bone healing hasn't changed during my lifetime. It hasn't changed during my predecessor's lifetime. It's not going to change during my kid's lifetime. It is what it is. And so I like to try and make sure that I'm protecting what we fixed according to how bones heal. So after a period of non-weight bearing, A lot of times we do some progressive weight bearing. If I do soft tissue work, I'll tell patients once you've been immobilized, then we start physical therapy. Somewhere in that 3 to 5 month range, you kind of note the biggest gains and you kind of finally feel like, oh, yeah, I'm glad I did this. Up to that point, you're kind of questioning it. Any kind of bony work, fusion, osteotomies, sometimes it can take up to 4 to 6 months with a slightly longer period of non-weight bearing to kind of get enough therapy under your belt where you're like, oh, I'm kind of glad I did this now. I'm not having the pain I used to have. I can see the light at the end of the tunnel. But for any foot or ankle surgery, total recovery time is about a year. So you got to keep in mind you're off the foot, you're immobilized, you get atrophy and weakness, your leg will get skinny, it'll get stiff. And so all that stuff has to be worked out. And it's a cruel trick nature plays. You get very weak, swollen very fast, and it just does not recover as quickly as it goes away. And so even after those biggest gains in the first 3 to 6 months, beyond that, I tell folks, you're going to still see some steady gains. And I tell them it's kind of like one of these things where it's kind of a slow, steady improvement, where every month you should look back and say, I'm even better than I was a month ago. But regardless, that first 3 to 6 months, they note the biggest gains. They're better than they were before, and things just continue to improve from there. But it's a full year recovery.
How do children get bunions? Mine started at 12 years old.
Juvenile bunions are a whole different ball game. Sometimes there's a deformity to the joint that contributes to it. I don't know that we have a great answer for that, but juvenile bunions are slightly different. Typically, I would recommend waiting until maturity until you have it addressed. But it's a slightly different ball game.
Once you do the surgery, will the marble go away?
That is the idea, right? So if you're balancing the weight, those smaller bones shouldn't be loaded and shouldn't be taking the weight that they weren't intended to. So yeah, that's the whole premise of doing it.
Hammer toe and second toe caused by a bunion?
So it's not necessarily caused by a bunion, but it is related to the metatarsalgia. So the first metatarsal joint becomes unstable. The first metatarsal can't support the weight it was intended to, and now you're overloading the second metatarsal phalangeal joint. And I tell patients, think about it this way: this joint is overloaded, and so now this toe is pushing against this bone as it's overloaded, and it's trying to get out of the way, and so it hammers or drifts, and that's how the hammer toe develops. So it's not necessarily directly caused by a bunion, but it's caused by the arch breaking down.
What if you've had flat feet all your life and are developing a bunion in your late 50s?
If it doesn't hurt, ignore it. If it starts to hurt, it depends on what hurts. Does the bunion hurt? Does the flat foot hurt? I would be more inclined to address what hurts, and not necessarily address everything that I see. I mean, I see patients all the time with terrible looking X-rays, but you're just trying to treat what's causing the pain. So if the bunion hurts, you can address just the bunion. It doesn't affect what's going on with the flat foot. If the flat foot hurts, correcting the bunion would be part of fixing the flat foot.
Any way the recovery can be lessened so you can be walking sooner?
That kind of goes back to my point about bone healing, right? That's all well documented. The science is what the science is. There is no way to speed up bone healing that I'm aware of. I would know if it was there because I would love to offer it to my patients. There is no way to speed up bone healing. And so when you're doing these osteotomies or fusions, if those don't heal, that's really going to slow the recovery because that could potentially lead to revision surgery. So the goal is to do this once, get things to heal, and then leave it alone. If there was a magic pill that we could give to try and allow things to heal predictably and faster, I would love to see it. I would give it to everybody that I did surgery on, and I'd never have to worry about bones not healing or healing slowly. But unfortunately, bone healing is what it is, and there's no way around it. I know, again, some implants talk about trying to allow early weight bearing, but it doesn't change the fact that bone healing requires rigid stability and compression. And if those aren't followed, you're increasing the risk for bones not to heal or to move or shift, and then increasing the potential for revision surgery.
Why does plantar fasciitis come and go?
I think the arch goes through phases of collapse. I see lots of patients that come in for plantar fasciitis and say, "Hey, I had a bout of this 10 years ago." Um, I don't know that it's a constant failure of the arch. I think it goes through kind of a cyclical nature where as it starts to collapse, you start to get the symptoms. Things kind of settle in, and then as enough tension is there, things can continue to collapse. I think that's why it can come and go.
What types of things should a person avoid so not to make a bunion worsen over time?
There isn't really anything you can do to not make it worse. What I tell folks when I see them, the 9 out of 10 patients that I say, hey, you probably don't need surgery yet. I tell them stretch your calf as best you can and just monitor for symptoms. There's no way to turn the clock back once that's developed, but you can try to control symptoms.
Tell me about bunionette surgery with a bone spur on left side of foot. How do you treat it?
So a bunionette is different than a bunion. So the bunion is on the big toe, right? And it's because that first metatarsal has drifted towards the midline or towards the other foot because of the instability here. Bunionette is a natural curvature to this fifth metatarsal. That hasn't changed. That's been that way since the patient was born. Um, a bunionette starts to cause pain as the arch fails and the foot tries to get longer. As it tries to get longer, it tries to get wider. And so that bunionette gets overloaded. And so the first thing I do, and the patients I saw today with that problem, we start with a little insert with a recessed area here to try and offload that. Typically, the bunionette's associated with a callus and pain over that area, and that callus is just a sign of that skin being overloaded in a place it wasn't intended to. And so I use an insert with a recess to try and offload that. And if that works, you don't need surgery. If it continues to hurt and that doesn't work, I basically will come in from the side and do an osteotomy and then rotate the bone and make it straight. So this is the time where the bone is actually crooked, and then I make the bone straight. Typically, that involves making an osteotomy along the bone here on the side, swing it back straight, and then plate and screws to help hold that compressed and stable so it can heal in that new position.
I've had 2 surgeries on my right foot, bunion, then hammer toes. Hammer toe surgery failed, and the bunion is starting to bulge. Can you fix the hammer toes?
Well, and so if you go back to the earlier question, right, the hammer toe isn't, in my opinion, an isolated problem. When I do hammer toes, I'm typically addressing the arch collapse to make sure that the weight at those joints that causes the hammer toe to develop is balanced and those joints aren't overloaded. So fixing that, if the bunion's starting to recur, they probably did some type of an osteotomy. I would want to address the bunion and get that first metatarsal fused here so that that first ray could support the weight it was intended to, and then potentially shorten down the lesser metatarsals to decompress that joint. It's amazing when I do that, when I swing that around and shorten these down, all of a sudden the toe wants to lay flatter. Sometimes with a hammer toe, you get that rigid deformity at the knuckle. And so it's obviously not going to lay flat if it's a rigid deformity. And so you have to do the hammer toe repair at that point. A lot of times, if you've had a hammer toe repair, they've tried to fuse that knuckle in the toe, and then the toe doesn't necessarily hammer, but it'll start to drift and move in different directions as that joint is still overloaded, as it's trying to get out of the way from that excess pressure. So doing the hammer toe by itself probably isn't going to work very well again.
Where do you do surgery?
So most of the surgery I do, I'd probably say 80% of it is considered 80 to 90% is considered outpatient. And I work out of the New Albany Surgery Center, which is Mount Carmel affiliated, or the Pickerington Surgery Center, which is Ohio Health affiliated, not hospital owned, but affiliated. So I'm in both systems.
If the first 3 toes separate from the smaller 2 toes, is this often an arch issue? Do orthotics help?
Yes, it's likely an arch issue. Again, weight shifting, those toes are starting to try to get out of the way from the overload to the base of those toes. If you have pain, yeah, you could do something with it. If you don't have pain or skin issues between the toes, I don't know that I would do anything.
Are corns a symptom of a bunion?
The, no, not necessarily, but you can get calluses on the big toe, and a lot of times I'll see it kind of near the knuckle, just by the nail here at the base of the nail, because that toe is rotated, and so you'll get calluses kind of on the inside of the big toe because that toe is loading abnormally. Remember, calluses, a corn is basically a callus, and it develops because the skin is getting pinched by the bone inside and the floor outside, and that's what causes that callus to develop because that's being loaded abnormally.
At what point is complete ankle replacement necessary?
So ankle replacement, obviously, if you're a candidate for it, like if you're, diabetic with some numbness, not a good candidate. If you've had a previous infection from like an ankle fracture, not a good candidate. Um, Typically ankle arthritis, I'd like to make sure patients have gone through conservative treatment. Anti-inflammatories, activity modifications. You can do bracing. I do a lot of injections under X-ray. Arthritic joints become much more narrow than they are when they're not arthritic. And so I like to use X-ray to make sure I get the needle in the joint, and I do a lot of steroid injections that way to buy time. If we've done all that, the injections aren't working very well, and they typically do diminish the effectiveness over time. Then an ankle replacement is reasonable as long as you don't have any contraindications to doing it.
I have a bunion and metatarsalgia, so regular calf stretching can help with all the pain and numbing.
The numbing is probably not from the bunion. It's probably from the irritation of that nerve between the metatarsal bones. Um, the stretching alone may not be sufficient. You may need the orthotic to try and redistribute the weight off those lesser metatarsal bones.
I've had two surgeries on my right foot and the marble is still there.
So obviously, I don't know what the X-rays look like or what the foot looks like, but um, you know, hard to say. Hard to say. Sorry.
What did you say again about the possibility of fixing the hammer toes?
I don't routinely do isolated hammer toe repairs because it's not part of it's not an isolated problem. It's all part of the arch breaking down and the weight shifting places it shouldn't be. So I routinely shy away from doing isolated hammer toe repairs. Hammer toes have a tendency to kind of be tricky. And I think it's because if we don't address how the weight is hitting the foot, those toes can want to drift and move even after you fix them. And so a hammer toe, again, is not a problem all by itself. It's part of a bigger issue. And so typically, if you rebalance the weight on the foot, um, the hammer toes typically don't change.
What causes a non-pain sprained second toe that was jammed in 2018 not to go back to normal? The base is a little wider than before.
Well, I mean, you could have had, I don't know what the x-rays look like. You could have had a little fracture if you didn't have it looked at. You could have some arthritis developing there associated with the injury. But more than likely, it's still overload because that your arch is probably breaking down gradually and leading to that. These tight calf muscles are just as common as tight hamstrings. The reason I wrote that, I looked at that paper and published that was because, I would see people talking about tight calves and they didn't believe it. And I'd watch them do the exam and they didn't know what they were doing. So, it exists and it's just as prevalent as tight hamstrings. And that leads to an arch collapse, you know, regardless of who you are. So, that sprain, I saw a patient today sprained the foot, the forefoot was had metatarsalgia symptoms. If you've got a mechanical setup for that, where the second metatarsal is maybe a little bit too long, you've got a tight calf, the first tarsal metatarsal joint's a little fatigued. You sprain it, you may not break anything, but you can flare up that metatarsalgia even though you didn't have it before the injury.
Are barefoot or flat shoes with wide toe box beneficial for foot health and better than wearing highly cushioned shoes, or does it really make a difference?
That's a good question. I don't think no shoe is ever going to fix any problem. It's not able to. The orthotics are attempting to redistribute weight on the foot to control symptoms. No shoe can do that. Interestingly, there was a fad kind of going back to barefoot running several years ago. That became a real popular topic, and part of the question is the shoe wear that we all wear, has that led to kind of breeding weakness in our feet that leads to this stuff? It intuitively it makes sense. But for me, the shoe itself makes no difference. If you have a foot problem, um, it's not going to be corrected with the shoe because it cannot redistribute weight. It's not going to have the metatarsal pad or the posting that's necessary to help redistribute the weight. So the shoe for me is a vehicle if you have a problem to hold the orthotic to try and treat the foot problem.
How do you fix overlapping toes?
Well, it depends, right? So if it's the second over the third, or if it's the first over the second, um, obviously the toes overlap because these joints are overloaded and the toes are trying to get out of the way. So it would be kind of a type 2 deformity. The first ray is unstable and tired now. You've got a tight calf muscle. Uh, and so, again, that would the overlapping toes are kind of equivalent to hammer toes. So I don't fix those in isolation. I'd want to balance the weight, stretch the calf, fuse the first tarsal metatarsal joint, shorten the metatarsals down because I would almost guarantee they're too long, and then deal with the metatarsal phalangeal joints, capsulotomies, maybe pinning, try to let them scar because if the toes are crossed, one side of the joint is really stretched out, the other side is really contracted. So you have to release the contracted side. A lot of times you'll then just try to pin it in place to try to let things scar in that neutral position.
How do you remove bone spur from bunionette's left side of foot? Do you minimally invasive do it in minute do you minimally invasive surgery?
Well, bone spur, my question would be, is it truly a bone spur or is it a bunionette? Um, Going in and shaving off a piece of bone, if the bone is curved, may not get you what you're looking for. Doing it minimally invasive, I'm not sure that's a great idea on that small bone. You don't need a big incision if you just are going to take a bone spur off. You stick that burr in. If you try to do it minimally invasive, you've got a nerve that lives in that area. You could wrap up in that burr. You could damage the skin, the overlying skin, because it's pretty close to underneath that skin layer, and so I'd be hesitant to do that minimally invasive.
Is it possible to have foot surgery with you and an Ohio Health doctor for pelvic organ prolapse, two surgeries in one, or being put under one time versus two?
Well, so that's a good question. We get that a lot. Unfortunately, we have certain days that we each operate on, and it's highly unlikely that those would overlap and we'd be able to do something like that. That'd be tough.
Have you ever heard of a seed callus? I've had a recurring one on one end of my toes. I use a callus remover to soften the skin, and you can find a small seed or stone that's there. It's really painful when there's one there. Curious
Hmm.
what causes it and if it's and is it removable so it won't return?
Well, my first question would be, what is it? If it's the end of the toe, you probably have some hammering to the toe, and it's loading more than it should. So if that toe's hammered and it's driving into the ground, you're going to keep getting a callus there. Again, those calluses develop when the skin is loaded where it wasn't intended to be, and so my assumption is that's probably what it is. So in order to correct that, you'd almost have to try to straighten the toe, assuming that's where it is.
Well, bunions eventually get worse if you don't do something about them. I've seen seniors with holes in their shoes just to accommodate their bunions.
Yeah, and I kind of talked about that earlier. Yeah, a bunion can get worse over time, but there isn't a bunion that somebody like me shouldn't be able to fix, no matter how bad it gets. So if it doesn't hurt bad enough, I wouldn't have it because there's no guarantee it's ever going to hurt bad enough that it needs to be fixed or it's ever going to cause skin irritation or concern for infection. It may never get to that point, so you may never need to have surgery. Um, that's what I tell folks. If it ever gets bad enough, it doesn't matter how bad the deformity is, we can still correct it.
How many appointments are needed for metatarsalgia with special inserts?
Typically, I see patients the first time just to confirm if that's what's actually the problem, look at the x-rays. And then that's typically, if they haven't already done orthotics, that's typically where I start. So first visit, then I typically see folks back in a few weeks to see if it made any difference. As I tell folks, we're using these temporary pads, sticking them on a temporary insert, trying to control cost. So we're not wasting a bunch of money on a custom orthotic to later find out it didn't help. And so then I see folks back, I tell them all, I say, if this doesn't help, don't lose hope. The first thing I do is I look to see if I need to adjust that pad. That's the advantage of doing these. I like to call them widgets. If anybody remembers what Back to School, Rodney Dangerfield, their mythical factory widgets, I use these widgets that I can play with things and try to dial it in. And if that works, we give it, 4 to 6 more weeks. And if it continues to work, then we do a custom orthotic. If that doesn't help, we've tried adjusting it, then we, typically we get an MRI at that point just to see if there's anything else that could be contributing before we talk about surgery.
If a foot has a bunion, but the big toe isn't crossing over the second toe yet, would you be able to shave the bunion bone without invasive surgery?
So again, the bunion is not a growth, and so if you shave that down, you're shaving away bone that could impact your big toe joint in the future. So I do not. That's called a silver bunionectomy. I do not recommend that. All right, because it's going to then progress over time, and then your salvage options, if you take a big chunk of this bone off, become much less optimal in the future.
I've seen my x-ray and I do have a bone spur on my left pinky toe. Can it be removed?
Of course. It just depends on where it is, and if you've tried sufficient non-surgical options. Because I would say the majority of patients I see now really haven't done much conservative treatment. So I spent a lot of time running through the conservative algorithm. If you got a little bone spur, there's little toe sleeves, little toe widgets you could try that may not require surgery. But yeah, you can take a bone spur off of a pinky toe.
And we're going to do our final 2 questions. What causes a plantar wart on the ball of the foot, and what is the guaranteed treatment to get rid of it? Can it return?
So I'm not a podiatrist, so I don't treat plantar warts. But the vast majority of the time when I get patients sent to me for a plantar wart, it's a callus underneath one of those metatarsal heads from overload. One of my partners is a podiatrist who manages the plantar warts, but I have not seen one of those come in to me that hasn't been just a callus from overload from metatarsalgia. So I couldn't tell you the guaranteed way to get rid of a plantar wart, but the vast majority of the time, it is not a plantar wart.
And the final question, if the bunion pain comes and goes, at what point should you schedule a consultation?
I tell folks if you're having more bad days than good, you can have the discussion. It doesn't necessarily mean that you need surgery yet, because again, the pain has to be bad enough that you say, I don't want to live with this anymore. But if you're having more bad days than good, it's worth having the discussion, having it looked at, and seeing what your options are.
Thank you, Dr. Cheney.
Thank you.
Thank you all for participating in tonight's webinar. Our next webinar is scheduled on March 5th. Dr. James Cassandra will be speaking about carpal tunnel syndrome. Enjoy the rest of your evening. Good night.